Okay, so morning friends, I'm Dr. Sushant Soni. I'm from AIMS Delhi and I'm your pathology faculty with Dr. Bhatia's institute. So today, starting with the pathology subject-wise tests. Today we start with the pathology subject-wise test in May 2018. So starting with the first question, section of lung showing. Now this is a pretty famous image because this came in this year's AIMS paper also, and the answer is 1A, and the answer is A, that is miliary TB. The answer is A, that is miliary TB. Now why is it miliary TB? Firstly, what it shows is a multitude of small tan granulomas. It is called as miliary TB because it shows a multitude of small tan granulomas which are about 2 to 4 millimeters in size. It is miliary, it is scattered like the miliary seeds, that is multiple small tan granulomas about 2 to 4 millimeters in size, which are scattered throughout the lung parenchyma. Firstly, this is the microscopy. Next, let us now see the other associated microscopies with this. So before we go further, this you very well know is miliary TB. This is miliary TB. Next, coming to the other microscopies, or before we go to the microscopies, just a sec. Before we go to the microscopies, let us first have a look at some theory part. Tuberculosis, you very well know, is divided into two types: primary TB and secondary TB. I need not even tell you, primary TB, this occurs in a previously unsensitized or an unexposed host. Primary TB, this is seen in a previously unexposed host. Next, the most common organ involved in primary TB is lungs. Most common organ involved, lungs. The site of involvement is, please put a double star on this, it is the lower part of upper lobe. Most common site of involvement, lower part of upper lobe and upper part of lower lobe. This is important. The most common site of involvement, lower part of upper lobe and upper part of lower lobe. Next point, it has three named foci, which are Gons focus, which is a grey-white area of inflammation, with consolidation. This is Gons focus. Next is Gons complex. Which is Gons focus plus regional lymph node involvement. And the next is Simon's focus. Which is occult hematogenous dissemination. To apex of lung. So primary TB has three named focus, which are Gons focus, Gons complex and Simon's focus. Before we go further, let us see what they look like microscopically. This was miliary TB. It showed scattered granulomas which are present all throughout. Next, this is Gons focus. What you have here is a area of just a sec. What you have here is the arrow which is even showing you a presence of area of consolidation close to the pleura, Ghon's focus, versus Ghon's complex, because we have Ghon's focus close to the pleura with involvement of regional lymph nodes. The lymph nodes are marked with an arrow. So Ghon's focus plus regional lymph node involvement is Ghon's complex. Next point. Next, we have already seen this is what miliary TB looks like in the lung. So involvement of the same in the spleen. What we have here is the cut surface which shows numerous grey-white tubercles. There are numerous small grey-white tubercles which are present on the spleen. So this is miliary tuberculosis of the spleen. Next, coming back to the theory, we have seen that tuberculosis, the first part was primary TB. Let me enlarge it. The first part was primary TB, which had 3 named foci. The next is secondary tuberculosis. Secondary tuberculosis obviously occurs in a previously sensitized host. It occurs in a previously sensitized host. The most common organ of involvement is again the lungs, and where in the lungs? The upper part. See, when we inhale air, more air goes to the upper part of the lung. So in the lungs, the most common part is apical and posterior segments. Apical and posterior segments of upper lobe of the lung. Apical and posterior segments of the upper lobe. And this lesion has a special name to it called as Pulse lesion. This lesion has a special name to it called as Pulse lesion. Next, there is another named lesion called as Assman's focus. Assman's focus, which is the infraclavicular lesion. Assman's focus, which is the infraclavicular lesion. So we have seen that primary TB was in an unexposed host, secondary is a previously exposed host. So do all patients of primary TB progress to secondary TB? Of course not. So this gets us to fate of primary TB. What is the most common fate of primary TB? Most commonly it is controlled by immunity. Most commonly it is controlled by immunity, leading to the formation of a calcified healed lesion, with hilar lymph nodes, with calcified hilar lymph nodes, and this healed lesion is called as Ranke's complex. This healed lesion is called as Ranke's complex. So fate of primary TB, most commonly it is controlled by immunity. And what do we mean by most commonly? In more than 95% of the cases. So we have seen primary TB, fate of primary TB, and secondary TB. This gets us to the last point, that is extrapulmonary TB. This gets us to the last point, that is extrapulmonary TB. Just a sec. Just give me a sec. So extrapulmonary TB, the most common site of involvement is lymph nodes. The most common site is lymph nodes. And which is the most common group of lymph nodes involved? The cervical group of lymph nodes, firstly. Next point in this is genital TB. Genital TB, in case of males, we are having slight technical issues, so don't worry about that. Genital TB, in case of males, the most common site is epididymis, whereas in females, the most common site is fallopian tube. Most common site is fallopian tube. So this was extrapulmonary TB. Most common site, lymph nodes. Most common group of lymph nodes, cervical group of lymph nodes. Next is genital TB. In case of males is epididymis, whereas in females is fallopian tubes. And last point is skeletal TB. Skeletal TB, where the most common site is spine, followed by hips and knees. And what is the spinal TB called as? The spine TB, it is pot spine. Pot spine. So this takes care of your first main topic in lungs, that is tuberculosis. This gets us to the next question, that is question number 2. This gets us to the next one, that is a 30-year-old female with neck swelling. Gross is shown. Gross shows a massively enlarged thyroid. Fair enough, not much information is gathered from this. Let us now see the microscopy part. This is important. Microscopically, what you are able to see here is a dense lymphocytic infiltrate with well-defined germinal centers in thyroid, making it as D, that is Hashimoto's thyroiditis. So question number 2, the answer is D, that is Hashimoto's thyroiditis. Hashimoto's thyroiditis. So before we go further, let us see what we mean by this. So let us start with the broad heading of hypothyroidism. So starting with hypothyroidism. Hypothyroidism. First point, hypothyroidism. In this, the thyroid production is reduced. What are the causes? I can divide it into primary hypothyroidism, which is an intrinsic abnormality of the thyroid. Primary hypothyroidism, this is intrinsic abnormality of thyroid. This can either be congenital, which occurs because of endemic thyroid deficiency. Endemic iodine deficiency, my mistake, endemic iodine deficiency. Next, it can be because of thyroid dysgenesis. Endemic iodine deficiency. Next, thyroid dysgenesis. What do we mean by thyroid dysgenesis? The mutations in PAX8, TSH receptors, or thyroid agenesis / hypoplasia. Any hypoplasia, that is any cause of congenital reduced thyroid, iodine deficiency, thyroid dysgenesis. Next is autoimmune. Next cause of hypothyroidism is autoimmune thyroiditis, which is Hashimoto's thyroiditis. Autoimmune in nature, that is Hashimoto's thyroiditis. Next, secondary hypothyroidism. This was primary, congenital or autoimmune. Next is secondary hypothyroidism. This occurs because of pituitary or hypothalamic deficiencies. That is secondary hypothyroidism. Next is iatrogenic hypothyroidism. It can be iatrogenic in nature, which is because of surgical removal or surgical ablation of thyroid. Surgical ablation of thyroid. This is hypothyroidism. We divided it into primary, secondary and iatrogenic. Next, so starting with our main topic, that is Hashimoto's thyroiditis. Starting with our main topic, that is Hashimoto's thyroiditis. Hashimoto's thyroiditis. First point, this is the most common cause of hypothyroidism. Hashimoto's most common cause of hypothyroidism in iodine sufficient areas. Hashimoto's thyroiditis, it is the most common cause of hypothyroidism in iodine sufficient areas. Next point, the genes involved in this are CTLA4 and PTPN22. The genes involved in Hashimoto's, they are CTLA4 and PTPN22. Next, it is associated with other autoimmune diseases. Like type 1 diabetes, SLE, that is lupus, myasthenia gravis, type 1 diabetes, lupus, myasthenia gravis and Sjogren's syndrome. All these, they are the other autoimmune diseases associated with Hashimoto's thyroiditis. Next point, it is also associated with, so the first point was other autoimmune diseases. Next, it is also associated with B cell NHLs. Next, extremely important, coming to the microscopy in Hashimoto's. Microscopically, it shows dense lymphocytic infiltrate. With well-defined germinal centers. Dense lymphocytic infiltrate with well-defined lighter areas, and lighter areas are the germinal centers. It shows dense lymphocytic infiltrate with well-defined lighter areas, which are the germinal centers, with entrapped thyroid. This is Hashimoto's thyroiditis. So before we go further, let us have a look at what it looks like microscopically. This was the image which was asked in your exam. What you have here is the presence of thyroid. We can see it on the right hand side. Unfortunately, I guess I'll not be able to write it. Can I? Yes. What it shows here is the presence of thyroid with dense lymphocytic infiltrate. All these small cells, they are the lymphocytes with well-defined lighter areas, which are the germinal centers, making this as Hashimoto's thyroiditis. Next, this, you tell me, this stands for, firstly let us see the parent tissue. Parent tissue obviously is thyroid. It shows us thyroid follicles with colloid in it, again with dense lymphocytic infiltrate with well-defined lighter areas, which are the germinal centers, with entrapped thyroid, making this again as Hashimoto's thyroiditis. Next, this gets us to a disease totally opposite of Hashimoto's thyroiditis, which is Graves' disease. This gets us to a disease opposite of Hashimoto's thyroiditis, that is Graves' disease. Hashimoto's was the most common cause of hypothyroidism in iodine sufficient areas, whereas Graves' disease is the most common cause of thyrotoxicosis. Graves' disease is the most common cause of thyrotoxicosis. Next point, it is again female predominant with age group of 20 to 40 years. Next, like Hashimoto's, this is again an autoimmune disease. It is an autoimmune disease associated with antibodies against TSH receptors. But the only difference is these are the thyroid stimulating antibodies, so they are associated with an increase in thyroid. So which are the antibodies which are seen in this? These are the thyroid stimulating immunoglobulins. That is TSIs, thyroid stimulating immunoglobulins, and LATs, which stands for long acting thyroid stimulators. That is LATs. Next, which type of antibodies are these? IgG or IgM? They are the IgG type. Next point, hormonally, that is endocrine. Hormonally, they are associated with increased free T3 and T4 levels. This is thyrotoxicosis, so obviously T3 and T4 are elevated. But point to be noted here is increased T3 and T4 gives a negative feedback to TSH. So TSH is reduced. Last point, microscopy. Extremely important. Please put a double star on this. Microscopically. Now what we will have in this are thyroid follicles with colloid. Fair enough. But this colloid is taken up by thyroid follicular cells and getting converted to T3 and T4. So microscopically it is associated with scalloping of colloid. Near thyroid follicular cells. This is Graves' disease. So before we go further, let us see what it looks like microscopically. This is Graves. Let us see with arrows. What we have here is the presence of thyroid follicles with colloid in it. This is colloid, thyroid follicles with colloid. Point to be noted here is there are clear white areas right next to the thyroid follicular cells, which are seen in all the thyroid follicles, called as scalloping of colloid, seen in Graves' disease. Done. This gets us to the next question, that is question number 3. CD59 deficiency leads to, and the answer is D, that is PNH. Question number 3, PNH, paroxysmal nocturnal hemoglobinuria, PNH. First point, what is PNH? Hemoglobinuria is taking place at night, so that is not the classical presentation, but that is what we say in PNH, paroxysmal intermittently nocturnal hemoglobinuria. Why? Starting with the pathogenesis of PNH. What do we do at night? You must be studying a bit more, but you also sleep at night. So when the patient sleeps, PO2 reduces, PCO2 increases. This in turn reduces the pH in the blood. Reduced pH is an activator of complement pathways. It is an activator of complement pathways. When the complement pathways are activated, this in turn leads to hemolysis. This in turn leads to hemolysis. But by this principle, all of us should be patients of PNH. What differentiates us, that is a normal individual, from a patient of PNH? In us also complement is activated, but hemolysis is not taking place. What prevents it? Our RBCs, we have CD55 and CD59 on their surface. CD55 stands for TAF, which is decay accelerating factor, whereas CD59 stands for MIRL, that is membrane inhibitor, of reactive lysis. The normal role of CD55 is it stops the action of C3 convertases, whereas CD59 stops the action of MAC. MAC stands for membrane attack complex. What is MAC? It is C5b to C9. It stops the action of MAC. Next point, patients of PNH, they are deficient in CD55 and CD59. So in them, when the complement is activated, it in turn leads to hemolysis. This is PNH. So PNH, it is deficient in CD55 and CD59. Next point, which deficiency is more severe, 55 or 59? It is the deficiency of CD59. Which deficiency is more severe? It is the deficiency of CD59. Next point, PNH, is it inherited or acquired? It is an acquired mutation. PNH, it is an acquired mutation in PIGA gene, present on X chromosome. PNH, it is an acquired mutation in PIGA gene present on X chromosome. Because of this acquired mutation, there is deficiency of GPI-linked anchor proteins. Because of this, there is deficiency of GPI-linked anchor proteins. There are numerous GPI-linked anchor proteins. The pathologically important are deficiency of CD55 and CD59. This is the pathogenesis of PNH. So when somebody asks the pathogenesis, don't start with sleeping. Don't start with deficiency of CD55 and 59. What you start with is an acquired mutation in PIGA gene present on X chromosome, which in turn leads to deficiency of GPI-linked anchor proteins, the most significant of which is 55 and 59. Done. This is PNH. This gets us to the next question, that is question number 4. This gets us to the next one, that is question 4. Which of the following is an epithelial tumor of the stomach? See, easy. Leiomyosarcoma is mesenchymal. Lymphomas are a separate category altogether. GIST stands for gastrointestinal stromal tumor. The very fact that it is a stromal tumor means it is mesenchymal, not epithelial. So what is left is D, that is gastric adenocarcinomas. So question 4, the answer is D, that is gastric adenocarcinomas. Gastric adenocarcinoma. So let us start with gastric adenocarcinomas. Firstly, this is the most common gastric malignancy. Gastric adenocarcinomas, they are the most common gastric malignancy. Next, there are numerous ways to classify it. So starting with the classification of gastric adenocarcinomas, starting with their classification, the first way to classify them is microscopically on the basis of Lorentz histological classification. The first way to classify gastric adenocarcinomas is microscopically on the basis of Lorentz histological classification, which divides gastric adenocarcinomas into intestinal and signet ring cell type. Into intestinal type and signet ring cell type. Intestinal and signet ring cell type. Which one is associated with a poorer prognosis? That is signet ring cell type. Poorer prognosis, signet ring cell type. Next point, which mutation is seen in signet ring cell gastric adenocarcinomas? E-cadherin mutation. Extremely important. Please put a star on this. Mutations seen in signet ring cell carcinomas CIT, E-cadherin. Next, the next way to classify gastric cancers, the first was microscopic. The next way to do so is based on the depth of invasion. Based on depth of invasion. Again, we can divide gastric adenocarcinomas into early and late type of gastric cancer. Early and late gastric cancer. Early gastric cancer, this is limited to submucosa. Early gastric cancer, it is limited to submucosa, whereas late goes beyond submucosa. Late gastric cancer goes beyond submucosa. So, if you have a question, gastric carcinoma limited to submucosa with aortic group of lymph nodes, would it be early or late? It is early gastric cancer. It is early gastric cancer. Why? Do not think that if the aortic is involved, it is late. No. The problem with this classification scheme is it does not take into account the lymph node status. It does not take into account the lymph node status. So is it a good scheme or a bad scheme? It's a bad scheme. It's no longer used. So this was the second way based on depth of invasion. The third way to classify gastric adenocarcinomas is grossly. Grossly. I can divide it into three types, which are exophytic, that is it goes up, flat, and excavated. Flat and excavated. These are the only three things that can happen. It will go up, remain flat, or go down. Exophytic, flat, excavated. Worst prognosis, flat type. Worst prognosis, flat type. Why? Because it is detected late. Because it is detected late and has spread by the time it is detected. And this has a fancy name to it called as Linitis plastica. This has a fancy name to it called as Linitis plastica. Done. So gastric adenocarcinoma, this was the most common gastric malignancy and is an epithelial tumor. Next, This gets us to the next question, that is question number 5. All of the statements given about this are true except. So before we go further, let us identify the instrument. This is a Jamshedi bone marrow biopsy needle. This is a Jamshedi bone marrow biopsy needle. Now let us see the options one by one. Done for diagnosis of infiltrative and granulomatous diseases, bone marrow biopsy very well, you can do it for that. No need of breath holding during the procedure. Fair enough, you need not hold the breath. Can be done in prone or lateral position. Agreed. Platelet count less than 40,000 is a contraindication. Of course not. On the other hand, bone marrow examination is recommended in patients of thrombocytopenia. So, coming to question number 5, the answer is D. Coming to question 5, the answer is D. That is, platelet count less than 40,000 per microliter is a contraindication. This is false. This is false. It is not a contraindication. It is not a contraindication. So the instrument that was shown was a Jamshedi bone marrow biopsy needle. The instrument was Jamshedi bone marrow biopsy needle. Rest we have already discussed. Next, this gets us to the next question, that is question number 6. This gets us to the next one, that is question 6. This is a spotter. Forget the question, let us just have a look at the image first. What this shows you is the presence of a large binucleate cell with large prominent nucleoli. It is a Reed-Sternberg cell or an RS cell. Reed-Sternberg cell is seen in Hodgkin's lymphoma. It is seen in Hodgkin's. So let us now see the question. 10-year child bilateral cervical lymph node was performed, which is true. So which is true about this? Answer is A. It is Hodgkin's lymphoma, EBV and embryo cell. So let us see the options with this. Question number 6. Question 6, the answer was A. Hodgkin's lymphoma. It is associated with EBV and RS cells. Wait, let us just a sec, guys. The answer is A, not A, D. Hodgkin's lymphoma, EBV and RS cells. EBV and RS cells. That was a Reed-Sternberg cell. My mistake. So let us see what we mean by this. Starting with classification of Hodgkin's lymphoma, the most commonly used classification is the Real/WHO classification. For Hodgkin's, the most commonly used classification is the Real/WHO classification, which divides Hodgkin's into two types: classical and lymphocyte predominant. Classical and lymphocyte predominant. Classical Hodgkin's, it is again of 4 types, which are mixed cellularity, nodular sclerosis, mixed cellularity, nodular sclerosis, lymphocyte rich and lymphocyte depleted. Mixed cellularity, nodular sclerosis, lymphocyte rich and lymphocyte depleted. First point, most common Hodgkin's in India, mixed cellularity. Most common in India, mixed cellularity. Easy to remember, we are a secular country, we are a mixture of everybody. So most common in India, mixed cellularity, whereas most common in West is nodular sclerosis. Next point, best prognostic Hodgkin's lymphoma, lymphocyte predominant. Best prognosis, lymphocyte predominant. Worst prognosis, lymphocyte depleted. Worst prognosis, lymphocyte depleted. Lymphocyte depleted. Next, Hodgkin's lymphoma microscopically shows the presence of RS cells, Reed-Sternberg cells, in a reactive background. The last two words are again important. It shows the presence of RS cells in a reactive background. Reactive background means that in the background we see the presence of all the cells, plasma cells, eosinophils, lymphocytes, monocytes, everything is there. That is a reactive background. Next point, I need not even discuss the markers of RS cells. They are CD15 positive, CD30 positive. Has been asked so many times that now they have stopped asking this. What is asked is which RS cell is CD15 and 30 negative. That is, RS cells are 1530 positive except those seen in lymphocyte predominant, which are CD15 negative, CD30 negative. So which marker are they positive for? They are CD20 positive. Extremely important. Next point, CD45 goes opposite. Classical is CD45 negative, whereas in lymphocyte predominant it is CD45 positive. But I am not much concerned with 45. What I am very concerned with is CD20. CD20. Done. These are the RS cells. We will be seeing the variants of RS cells in a later question. Next, this gets us to question number 6. No, this was question 6. This gets us to the next question, that is question number 7. This gets us to question 7. Cleft-like spaces in an atheromatous plaque. The cleft-like, that is the white spaces in an atheromatous plaque. It's not smooth muscle, fibrous tissue, no. It is cholesterol. So question 7, the answer is C, that is cholesterol. The answer is C, that is cholesterol. So before we go further, let us have a look at the microscopy of an atheromatous plaque. Before we go further, let us have a look at microscopy of atheromatous plaque. The cleft-like spaces were cholesterol, that's okay. Now microscopically in atheromatous plaque, it shows us 3 areas, which are fibrous cap. It shows us 3 areas, which are fibrous cap, composed of fibrous cap. This is composed of smooth muscle cells, and dense collagen. Composed of smooth muscle cells and dense collagen. The next area is the shoulder area. Shoulder, this is the most cellular area. It is the most cellular area in an atheromatous plaque, and it is composed of macrophages, T cells and smooth muscle cells. Macrophages, T cells and smooth muscle cells. So microscopically it has fibrous cap, shoulder area, and the last is necrotic core, which contains lipid and foam cells. The cholesterol clefts or the cleft-like spaces were cholesterol. So 3 areas microscopically: fibrous cap, shoulder, and necrotic core. So before we go further, let us see what this looks like microscopically. Before we go further, we have already seen this image. Diagnosis was Graves' disease. Fair enough. Next, this shows you the classical RS cell, Reed-Sternberg cell, binucleate with prominent nucleoli. Next, these were the variants of RS cells. Let us have a look point by point. Before we go further, let us look at the variants here only. The first variant of the RS cell is the lacunar type. This is the lacunar type of RS cell. Lacunar type of RS cell. We'll see subsequently where it is seen. What you have here is a binucleate cell with a cleared lacuna around it. Cleared lacuna around it. Whereas this is the popcorn type of RS cell. The popcorn cell or L&H cell. Popcorn cell or L&H, that is lymphocyte and histiocytic cell. These are the variants. We'll see them again subsequently. Next, this gets us to our current question, that is diagnosis. What we have here is a blood vessel. This is the blood vessel in which the vessel lumen is narrowed. Why? Because of an atherosclerotic plaque which has three areas. This blue dense area is the fibrous cap. It is the fibrous cap. Next is the shoulder area. This is the shoulder area which is the most cellular, and the one which is deep to the fibrous cap composed of lipid and foam cells is the necrotic core. This is atherosclerosis. Next point, coming back to the theory, this gets us to the sites or vessels involved with atherosclerosis. The vessels involved. Again, repeatedly asked, the most common vessel involved is the lower abdominal aorta. That is the descending aorta or the lower abdominal aorta. The most common vessel involved, abdominal aorta. Next point, the other vessels involved are coronary arteries. Coronary arteries, which is the most common? Left anterior descending. Most common coronary artery involved, left anterior descending. Next, popliteal arteries. Popliteal artery, this is the most common peripheral vessel involved. Popliteal artery, this is the most common peripheral vessel involved with atherosclerosis. That is popliteal arteries. The others are internal carotid arteries and those of circle of Willis. Internal carotid arteries and those of circle of Willis. This is the descending order of involvement with atherosclerosis. Done. This gets us to the next question, that is question number 8. This gets us to the next one, that is question number 8. Dark granulomas are seen in brain. The answer is A. Question 8. The answer is A. That is dark granulomas. They are seen in brain. So before we go further, let us see what we mean by this. In cerebral malaria, firstly, what is a dark granuloma? It is involvement of brain with malaria. So in cerebral malaria, the entire capillary network of brain, is descended. The capillary network of brain is distended. That is, it is dilated and is occluded by, parasitized erythrocytes. First point. What this means is, in cerebral malaria, the capillaries are distended, they are dilated, and there is occlusion of the capillaries by RBCs, which are parasitized or which have malaria in it. Next point, because of this, it is also associated with perivascular ring hemorrhages. Next feature, it is associated with perivascular ring hemorrhages and softening. Third feature is, first was it is distended, next was perivascular ring hemorrhages, and next it is also associated with softening because of degeneration of nervous tissue. Softening because of degeneration of nervous tissue. Degeneration of nervous tissue. This is the microscopy of cerebral malaria. Now, point to be seen here is this softened degenerated nervous tissue. This is invaded by glial cells. Later, this is invaded by glial cells. These are the reactive glial cells which are in turn proliferating, and in return they lead to the formation of dark granulomas. Dark granulomas, they are the granulomas in malaria seen in brain. This is a result of reparative action, that is, now healing is taking place. What are they? This is a result of reparative action. To local damage. This is a result of reparative action to local damage. That is a dark granuloma. Done. Next, this gets us to the next question, that is question number 9. This gets us to the next one, that is question 9. A patient received blood transfusion. Patient has received 8 blood transfusions in last few years. Still the hemoglobin is low, RBC count is low, MCV low, which is not required. Test for pulmonary hemosiderosis. This is required. Next, why hemosiderosis? Because of multiple blood transfusions, that in turn leads to hemosiderosis. Next, GI endoscopy. This is also required because why are the multiple blood transfusions needed? You need to rule out the cause of internal bleeding. So GI endoscopy is required. Urine hemosiderin, again repeated blood transfusions leading to iron overload. Urine hemosiderin examination is required. Bone marrow examination. No, this is not. So the answer to question 9 is D. The answer is D. That is bone marrow examination. Answer is D. That is bone marrow examination. In this, the examiner mainly wanted you to know that repeated blood transfusions in turn can lead to iron overload. It can lead to iron overload or hemosiderosis. Iron overload or hemosiderosis. We'll be doing this subsequently in detail. Hemosiderosis, iron overload. As a result, you need to test for pulmonary hemosiderosis as well as you need to test for urine hemosiderin. Next point, each unit of RBCs. Next point, how much hemosiderin or how much iron is taken with each transfusion? Each unit of RBCs, they contain about 200 to 250 milligrams of iron. This again is important, so please put a star on this. Each unit, it has this much iron. Done. This is question 9. Next, this gets us to the next question, that is question number 10. Question 10. Pale infarct is seen in all of the following except, and the answer is A, that is lungs. Pale infarct, it is seen in all except lungs. Let us see this slightly in more detail. Let us see this slightly in more detail. What do we mean by infarct? Infarct, it is an area of ischemic necrosis. Infarct, it is an area of ischemic necrosis. Area of ischemic necrosis due to occlusion of blood supply. Area of ischemic necrosis due to occlusion of blood supply. Next point, most common cause. Why do infarcts occur? The most common cause is thrombotic or embolic events. Most common cause being thrombotic or embolic events. Next point, I can divide infarctions into two types, red infarcts and white infarcts. This classification is important and has been repeatedly asked. Red infarcts and white infarcts. First point, red infarcts, they occur because of venous occlusion. Red infarcts, they occur because of venous occlusion, that is ovarian torsion. They occur because of venous occlusion, that is ovarian torsion. Next, they are also seen in loose spongy tissues. Loose spongy tissues like lungs. So lungs are associated with red infarcts, not white infarcts. Loose spongy tissue, that is lungs. Next, in areas of dual circulation, like again lungs and small intestine. Lungs and small intestine. These are red infarcts. Next point, red infarcts, they are usually ill-defined hemorrhagic lesions. They are ill-defined hemorrhagic lesions. They have ill-defined hemorrhagic lesions or margins, and edema is usually present. And in these, edema is usually present because either it's a loose spongy tissue or it has dual circulation, so it is associated with edema. Versus white infarcts, which occur because of endarterial occlusions. Versus white infarcts, which occur because of endarterial occlusions and are seen in solid organs like heart, spleen and kidney. Please put a double star on this. Extremely important. Heart, spleen and kidney, which is associated with white infarcts, versus lungs, small intestine and ovarian torsion, which is red infarcts. Extremely important. Next point, white infarcts, they have well-defined margins. White infarcts, they have well-defined margins and edema is usually absent. This is red infarct versus white infarcts. Last point. Microscopically, ischemia is associated with coagulative necrosis. Again, this statement has been repeatedly asked. Microscopically, ischemia is associated with coagulative necrosis. It is associated with coagulative necrosis. That is obvious. The question that is asked is, except in brain. It is associated with coagulative necrosis except in brain, where it is associated with liquefactive necrosis. Done. This is infarction. This is infarction, red infarct versus white infarct. This gets us to the next question, that is question number 11. This gets us to the next one, question 11. Maternal chromosome 15 disomy results in Prader-Willi syndrome. Results in A, that is Prader-Willi syndrome. It results in Prader-Willi syndrome. So, before we go further, let us have a good look at this. Genomic imprinting. Genomic imprinting. This is a topic which you need to understand. You will not be able to rectify this. So, genomic imprinting. What do we mean by this? Starting with extreme basics. The gene that is getting imprinted, is it expressing itself or is it not expressing? It is not expressing itself. The gene that is getting imprinted, the gene that is imprinted, it is not expressing itself. It is not expressing itself. If you know this, you will know everything about it. How? We can divide it into two types. So let us make a flow chart. Genomic imprinting, it is of two types, maternal imprinting and paternal imprinting. Maternal imprinting and paternal imprinting. First point, the disease associated with maternal imprinting is Prader-Willi syndrome. The disease with maternal imprinting is Prader-Willi syndrome, whereas the one with paternal imprinting is Angelman syndrome. Easy to remember. P and P do not go together. So maternal imprinting Prader-Willi, paternal imprinting Angelman. Next point, in this, which chromosome are we talking about? Chromosome 15. Chromosome 15. So starting with the pathogenesis, you very well know we get one chromosome from the mother, one from the father. So this is mother, this is father. In Prader-Willi, the chromosome of the mother is physically present, but it is not expressing itself. Maternal imprinting. Plus, what is happening to that of the father? It is getting deleted. So, Prader-Willi syndrome, it is maternal imprinting plus paternal deletion. You need to understand this. The chromosome of the mother is physically present but not expressing itself. Father's is deleted. Disease will occur when both the gene products will be absent. Versus Angelman, which is paternal imprinting, plus maternal deletion. That is Angelman syndrome. So, the first way of having the disease is by deletions. Please see it properly. Paternal deletion is seen in Prader-Willi, maternal deletion is seen in Angelman. Next point. The next way of having the disease is by disomy. The next way of having the disease is by disomy. Disomy is when both the chromosomes are inherited. They are inherited from same parent. Both the chromosomes are inherited from the same parent. That is disomy. So starting with Prader-Willi, Prader-Willi syndrome, just a sec. Prader-Willi syndrome, that was maternal imprinting. So both the chromosomes in Prader-Willi is coming from the mother. That is, it is maternal disomy. Prader-Willi is maternal disomy. Both the chromosomes are coming from the mother, but they are not expressing themselves. Versus Angelman syndrome, which is paternal disomy. Versus Angelman, which is paternal disomy. Last point, clinical features. Clinical features continue the same flowchart. Prader-Willi. If the mother is not at home, father and son sit in front of TV and eat food whole day. So it is associated with hyperphagia. Hyperphagia. Father is not taking the child to play basketball. Hypotonia. Hypotonia. Short stature. Hyperphagia. Hypotonia. Short stature. Mental retardation. Hypogonadism. Hypogonadism and mental retardation. This is Prader-Willi. This is Prader-Willi versus Angelman. If father is not at home, mother and daughter laugh crazily whole day. So the classical term is called as happy puppets. The classical term that we use with this is happy puppets. Just give me a sec. Happy puppets. Just a sec, guys. Happy puppets. So what is happy puppets? It is uncontrollable laughter plus ataxic seizures. Happy puppets. That is uncontrollable laughter plus ataxic seizures. Done. This finishes Prader-Willi and Angelman. This gets us to the next question, that is question number 12. This gets us to the next one, that is question 12. Before we go further, just give us 1 second. We are having slight technical issue. We'll get back to you within a sec. Just a sec. Okay. So starting with question 12. Okay, so I guess we are back on track. Perfect. So starting with question number 12. So starting with this, mutation of which, let me project the question for you. Mutation of which of the following is most important in PNH? We have already seen the pathogenesis of PNH. We have seen that in PNH, firstly, the answer is C. The answer is C, that is GPI linked anchor protein. In question 12, the answer is C, that is GPI linked anchor protein. And PNH, we have already seen in detail that it is the pathogenesis. It is an acquired mutation in PIGA gene present on X chromosome. Acquired mutation in PIGA gene present on X chromosome, which in turn leads to deficiency of GPI linked anchor proteins, which in turn leads to the deficiency of GPI linked anchor proteins. There are numerous GPI linked anchor proteins, the most significant of which are deficiency of CD55 and CD59. We have already seen this in detail. Which is more significant? Deficiency of CD59. So if you are asked in the pathogenesis, like in question 12, you will not mark 55 or 59. What you will mark is deficiency of GPI linked anchor proteins. That is PNH. Next point, before we go further, let us see one more point in this, that is PNH. The most common cause of morbidity and mortality. The most common cause of morbidity and mortality in PNH is thrombosis. The most common cause of morbidity and mortality in PNH is thrombosis. Now this thrombosis is interesting. Why? Because first point, the cause of thrombosis is unknown. The cause of thrombosis is unknown. Next, It occurs at unusual sites. It occurs at unusual sites, that is portal vein thrombosis, cerebral vein thrombosis. It occurs at unusual sites, that is portal vein, cerebral vein, and hepatic vein thrombosis. What is the special name associated with which thrombosis? Hepatic vein thrombosis. It has a special name to it called as Budd-Chiari syndrome. Hepatic vein thrombosis. It has a special name to it called as Budd-Chiari syndrome. Done. This takes care of question 12. This gets us to the next question, that is question number 13. Question 13. Let us have a look at the question. Diagnostic electron microscopic feature of paragangliomas is, the answer is D. It is associated with dense secretory granules. Paragangliomas, they are associated with dense secretory granules. So before we go further, let us see what they microscopically look like. Paragangliomas microscopically, I'll show you what they look like. They are composed of, microscopically, they are composed of polygonal chromaffin cells. Polygonal chromaffin cells or chief cells. Polygonal chromaffin cells or chief cells which are clustered into small nests. Which is called as the classical Zellbellen pattern. But it is clustered into small nests with a rich vascular network. This is paraganglioma, the light microscopy. It is composed of polygonal chromaffin cells or chief cells. You will have cells in clusters surrounded by a rich vascular network, and this appearance is called as Zellbellen appearance. Next point, chromatin. We are discussing the microscopy only. Next point, nuclei. The nuclei of paragangliomas, they have the classical salt and pepper chromatin. Why? Because it's electron microscopy. Because electron microscopy shows numerous membrane bound. Electron dense granules. And what is present in these granules? Catecholamines. That is catecholamines along with other peptides. This is the paraganglioma. Zellbellen pattern, we will see it subsequently in other questions. So, nuclei, salt and pepper chromatin, electron microscopy, numerous granules which contain catecholamine. So, the answer to question number 13 is dense secretory granules which are seen in paragangliomas. Next, this gets us to the next question, that is question 14. This gets us to the next one, that is question 14. Let us have a look at this. Question 14. Chromophilic renal cell carcinoma is associated with B, that is trisomy 7 and 17. The answer is B, that is trisomy 7 and 17. So before we go further, let us have a look at microscopic appearances of RCC, renal cell carcinoma. If nothing is written, we mean the conventional RCC. We mean the conventional or the clear cell RCC, which is associated with VHL mutations. VHL stands for von Hippel-Lindau. VHL stands for von Hippel-Lindau mutations present on chromosome. How many alphabets are there in VHL? 3. So present on chromosome 3. Next, the next RCC is the papillary. The next is the papillary or the chromophilic RCC. Papillary or chromophilic RCC, which is associated with chromosome 7 or CMET mutations. Papillary RCC, which is the chromophilic type associated with chromosome 7 or CMET mutations. The last is chromophobe RCC. Last is chromophobe RCC, which is associated with, the name tells you it is phobic of all the chromosomes. So it is associated with deletions or hypodiploidy. It is associated with deletions or hypodiploidy. This is RCC, renal cell carcinoma. Done. This gets us to the next question, that is question number 15. So starting with question 15. Patient with alpha-1 antitrypsin deficiency is most likely to have pan-acinar emphysema, that is D. That is D. Pan-acinar emphysema. Pan-acinar emphysema. So before we go further, let us have a look at emphysema in detail. Starting with emphysema. Emphysema, this is reversible or irreversible? Irreversible. It is irreversible dilatation. Emphysema, irreversible dilatation distal to terminal bronchiole. Emphysema, it is irreversible dilatation distal to terminal bronchiole. What is present distal to terminal bronchiole? Respiratory bronchiole, alveolar duct and alveolar sac, which is called as an acinus. So it is irreversible dilatation distal to terminal bronchiole. Next point, it is of 4 main types, which are centri-acinar emphysema, centri-acinar, pan-acinar emphysema, centri-acinar, pan-acinar, paraseptal and irregular type. So emphysema, it is of 4 main types, that is centri-acinar, pan-acinar, paraseptal and irregular. First point, most common emphysema, irregular. Most common, irregular. Next, when is it detected? Neonates, infants, children, elderly, after death. When is it detected? After death. It is an autopsy finding. It is an autopsy finding. So, is it clinically significant or non-significant? It is clinically non-significant in nature. Clinically non-significant. Next point, location. It has a patchy, irregular distribution. it has a patchy irregular distribution, that is irregular emphysema. Next question, most common clinically significant emphysema, centriacinar type. Most common clinically significant emphysema is centriacinar. When I say clinically significant, what percentage of people going to the doctors have centriacinar? More than 95%. More than 95. Next, so if it is clinically significant, of course this is the one that has strongest association with smoking. Strongest association with smoking. Next point, location. Location, when we inhale air, more air goes to the apex of the lungs. So when a person smokes, more smoke also goes to the apex, that is upper lobes of the lung. Location, upper lobes of the lung. Next point, coming to pan-acinar emphysema. If the whole acinus is involved, easy to remember, it settles down. So location, it is seen in lower lobes of the lung. Lower lobes of the lung, pan-acinar. And pan-acinar emphysema, this is the one which is associated with alpha-1 antitrypsin deficiency. Associated with alpha-1 antitrypsin deficiency. This is emphysema. This is emphysema. So most commonly associated with alpha-1 antitrypsin deficiency. Answer, pan-acinar emphysema. Pan-acinar emphysema. Done. Next, this gets us to the next question, that is question number 16. This gets us to question 16. Which of the following is least likely to be accompanied by lymphocytes in peripheral blood? The answer is C, that is bacterial infections. The answer is C, that is bacterial infections. See, this was sort of obvious because bacterial infections, they will play a role in the main cells that are associated with bacterial infections are neutrophils, not lymphocytes. Next, they lead to an acute inflammatory response. They lead to an acute inflammatory response with the main cytokines. With the main cytokines being involved are interleukin 1 and TNF alpha. Interleukin 1 and tumor necrosis factor alpha. So lymphocytosis would not be a feature of bacterial infections. Next, this gets us to the next question, that is question 17. False about fibrolamellar variant of liver cancer. First point, what do we mean by the fibrolamellar variant? It is the good prognostic variant. So on option D, that is AFP levels are usually raised, is false. Let us see this one by one. Let us see this one by one. So let us, the answer is D, that is AFP is raised, and let us now start with the theory part. Starting with HCC, hepatocellular carcinoma. First point, male predominant or female? Who usually drinks more? Males. So HCC, male predominant. Next point, who drinks more? Indians or Westerners? Westerners. But who is more predisposed to side effects? Indians. So it is more common in Southeast Asians. More common in Southeast Asians. Next point, HCC. Good prognosis, poor prognosis. It has a poor prognosis. If somebody has got liver cancer, of course it is poor prognosis. Next, however, there is a special subtype of HCC called as fibrolamellar variant. There is a special subtype called as fibrolamellar variant of HCC. Fibrolamellar variant of HCC. This is the good prognostic variant. This is the good prognostic variant of HCC. First point. Next point. If it is associated with a good prognosis, will it be associated with cirrhosis or not? Not associated. Cirrhosis is usually not seen. Next, focal or diffuse. It is focal in nature. AFP is not elevated. Focal in nature. AFP is not elevated. Seen in younger individuals. Please put a star on this. Next point. In this, males is equal to females. Rapidly growing or slowly growing? Slowly growing. It is slowly growing and grossly central stellate scar may be seen. Grossly central stellate scar may be seen. This is the fibrolamellar variant of HCC. So if you just remember that it is the good prognostic variant, you will know majority of the points with this. Important ones were younger individuals, AFP is not elevated, and males is equal to females. Done. This gets us to the next question, that is question 18. This gets us to the next question, that is question 18. Expression of following oncogene is associated with MEN2A and MEN2B, and the answer is C, that is RET proto-oncogene. Answer is C, that is RET proto-oncogene. An easy standard question. So before we go further, let us have a look at MEN syndromes. MEN syndromes. MEN, it is of three types: MEN1, MEN2A, and MEN2B. It is of three types: MEN1, MEN2A, MEN2B. MEN1 is also called as Wermer's syndrome. MEN1 is also called as Wermer's syndrome versus MEN2A, which is Sippel syndrome. Next point, MEN1. Organs involved are PPP, that is parathyroid, pituitary, and pancreas. Parathyroid, pituitary, and pancreas. Parathyroid is associated with parathyroid hyperplasia, which is both, let us write it here only, which is both the most common as well as the initial manifestation. Parathyroid hyperplasia. Next point, pituitary. The most common pituitary tumor is a prolactinoma. Which prolactinoma? Microadenoma or macroadenoma? Microadenoma. That is pituitary. Next point, which mutation is seen in MEN1? MEN1, it is associated with mutation in tumor suppressor protein menin. Which is present on chromosome 11. Next, this gets us to MEN2A and MEN2B. Starting with organs involved. MEN2A, the organs involved are ATP, that is adrenal, where it is associated with pheochromocytoma. Thyroid, which shows medullary carcinoma. Thyroid and parathyroid, that is parathyroid hyperplasia. This is meant to A versus meant to B, where the organs are AT, adrenal pheochromocytoma, thyroid, medullary carcinoma, with Marfanoid habitus. Meant to B with Marfanoid habitus and ganglioneuromas. With Marfanoid habitus and ganglioneuromas. Next point. Which mutation is seen in MEN2? When I say MEN2, I mean both MEN2A and MEN2B. Mutation seen in MEN2. It is associated with red proto-oncogene mutation. Associated with red proto-oncogene mutation present on chromosome 10. Present on chromosome 10. Extremely important. Done. This takes care of question 18. Next, this gets us to the next one, that is question 19. This gets us to Miagawa bodies are seen in LGV. Miagma bodies are seen in LGV. This is a factual question, more from micro, that they are seen in LGV. So before we go further, let us have a look at the various bodies with diseases associated. Starting with the important ones, that is Michaelis-Guttman bodies. Starting with the important ones, the first one being Michaelis-Guttman body, seen in Malakoplakia. Seen in Malakoplakia. Michaelis-Guttman bodies, Malakoplakia. Next, Miagawa bodies. This is an appendix. This has to be remembered. That is LGV. Miagma bodies, LGV. Next, Gamma-Gandhi bodies. Gamma-Gandhi bodies. They are seen in chronic venous congestion, CVC, chronic venous congestion liver, and sickle cell anemia. Gamma-Gandhi bodies, CVC liver, sickle cell anemia. Next, Mason body. Please put a double star on this. Extremely important. Mason bodies. I'll show it to you what they look like when we discuss the AIMS paper. Mason bodies. They are seen in cryptogenic organizing pneumonias. They are seen in cryptogenic organizing pneumonias. Mason bodies or cryptogenic organizing pneumonias. Next, Nigri bodies. These are the intracytoplasmic bodies. Seen in rabies. Next are the Muses bodies. Seen in endemic typhus. Muses body, seen in endemic typhus. And coming to the last one, that is hemotoxylin body. Hemotoxylin body, that is also called as an LE cell. Hematoxylin body or an LE cell, seen in lupus, SLE, that is Liebman-Sack endocarditis. SLE affecting the heart is called as Liebman-Sack endocarditis. I need not even talk about Schiller-Dovell bodies and stuff that you already know. So still, just to complete the list, let us write them. Schiller-Dovell bodies. Which ovarian tumor? They are seen in York-Sack tumor. Schiller-Dovell bodies, York-Sack tumor. Next, Kollexner bodies, seen in granulosa cell tumor. Collectional bodies seen in granulosa cell tumor. We'll be seeing it today only. Next, Aschoff bodies. Aschoff bodies, they are pathognomic of RHD, rheumatic heart disease. Aschoff bodies. Next, sarcoidosis. This is associated with asteroid bodies. Asteroid bodies and Schaumann bodies. Asteroid bodies and Schaumann bodies. We have seen them numerous times in our discussions that these are associated with sarcoidosis. These are associated with sarcoidosis. Coming to the last one, that is Russell bodies. Russell and Dutcher bodies, which are associated with multiple myeloma. Which are associated with multiple myeloma. Russell and Dutcher bodies seen in multiple myeloma. Done. This takes care of the list of bodies associated with various diseases. Next, this gets us to the next question, that is question 20. So, which is characterized by an eczematous reaction that occurs 72 hours after wearing latex? The fact that it is a delayed type of hypersensitivity reaction means it is associated with D, that is type 4 hypersensitivity. This is a delayed type. This is a delayed type of hypersensitivity, type 4 hypersensitivity. So before we go further, let us have a look at hypersensitivity reactions. Let us have a look at hypersensitivity reactions. There are 4 types of hypersensitivities, which are 1, 2, 3 and 4. Type 1 hypersensitivity is the allergic response. Type 1 is the allergic response, which is associated with asthma. Type 2 is antibody mediated hypersensitivity. Type 2 is antibody mediated hypersensitivity. Type 3 is antigen antibody immune complex reaction. Antigen antibody immune complex reaction. Whereas type 4 is delayed type of hypersensitivity. It is delayed type of hypersensitivity. I am sure you already know this. Next point, let us see the salient features of each. They are important. So starting with type 1 hypersensitivity. Starting with type 1 hypersensitivity, I'm not even going to tell you that most common immunoglobulin is IgE. Cells involved are mast cells and eosinophils. Cytokines involved, interleukin 4, 5 and 13. Which is the most potent activator of eosinophils? Interleukin 5. This is the most potent activator of eosinophils. Next point, which TH response, which type of T helper cell response is seen? TH2 response. This we'll see subsequently when we do the questions on immunity. Which helper cell response? TH2. The only point I am concerned with in type 1 hypersensitivity is the types of reactions. Type 1 hypersensitivity, it is associated with 2 reactions. An early response or an early reaction and a late reaction. An early reaction and a late reaction. The mediators involved in late reaction are important. It has 4 cytokines involved, which are interleukin 5, eotaxin, interleukin 5, eotaxin, MBP, that is major basic protein, MBP, and ECP, that is eosinophilic cationic protein. ECP, that is eosinophilic cationic protein. So late reaction, the mediators involved are interleukin 5, eotaxin, MBP and ECP, versus early reaction, which is associated with all the other mediators we can think of, that is histamine, leukotrienes B4, C4, D4, E4, platelet activating factor PAF, platelet activating factors, enzymes, that is chimases and tryptases. These are all the mediators involved in early reaction. Not much interested. What I am very interested are the mediators of late response. They are important. This is type 1 hypersensitivity. Next type 2 antibody mediated, type 3 antigen antibody immune complex. Let us not get into those. This gets us to the last one, that is type 4 hypersensitivity. This gets us to the last one, that is type 4 hypersensitivity. Type 4 hypersensitivity, the diseases associated are type 1 diabetes. Diseases associated are type 1 diabetes. Type 4 hypersensitivity, it is a delayed type of hypersensitivity reaction. So what is the antigen? The antigen is of pancreatic islet beta cells. The antigen is of pancreatic islet beta cells. Type 1 diabetes. Next is multiple sclerosis. The next disease associated with type 4 hypersensitivity, multiple sclerosis. What is the antigen involved? It is a protein antigen in CNS myelin. Multiple sclerosis, it is a protein antigen in CNS myelin. Next, the next disease associated with this is rheumatoid arthritis. Rheumatoid arthritis, this has an unknown antigen. The antigen is not known, it is an unknown antigen in joint synovium. Unknown antigen in joint synovium, that is in the joint synovium. The antigen is still unknown in nature. Next, the next disease of course is tuberculosis, where the antigen is Mycobacterium TB. This is type 4 or delayed type of hypersensitivity reaction. Now, which cells play a role in this? Macrophages and T cells. Which T cells, B or T? Both. Which T cells? CD4 positive or 8 positive? Both. CD4 and CD8 positive T cells. Done. This gets us to the next question, that is question 21. This gets us to the next one, that is question 21. Now, I know it's a big question. Before we even go to the question, let us have a look at the image. What this shows you is this is peripheral smear. How do we know it is peripheral smear? Because RBCs are well spread apart, which shows you the presence of mature appearing lymphocytes, which are similar in size as compared to an RBC. Mature appearing lymphocytes with presence of smudge cells. So diagnosis CLL. In such a question, I need not even know the history of the patient to come to a diagnosis. This can simply be asked as an image-based question without history, nothing. So let us now come to the question whether it is fitting into our diagnosis of CLL or not. Now, palpable spleen, non-tender lymphadenopathy, lab diagnosis, TLC count elevated. So everything fits into CLL, chronic lymphocytic leukemia. everything fits into CLL. So before we go further, let us have a look at the microscopy again. Just a sec. Before we go further, this was CLL. So starting with CLL, chronic lymphocytic leukemia, starting with its microscopy. Microscopically, CLL shows a high TLC. TLC is elevated with presence of mature appearing lymphocytes. If they are mature appearing matlab they are similar in size as compared to an RBC. How will I know that they are normal or abnormal? These mature appearing lymphocytes, they are CD19 positive, CD5 positive, CD23 positive. Extremely important. This is the classical triad of CLL: 19 positive, 5 positive, 23 positive. Next point, CLL, it is also associated with the presence of smudge cells. Please note, smudge cells, they are most commonly seen in CLL, but they can be seen in other neoplastic diseases also. So do not make a diagnosis of CLL only on the basis of smudge cells. Have a look at the whole image. Next point, characteristic RBC morphology. RBC morphology in CLL. CLL, it can be associated with which hemolytic anemia? Autoimmune. It can be associated with warm type of autoimmune hemolytic anemia. CLL, it can be associated with warm type of autoimmune hemolytic anemia. So AIHA is associated with the presence of which RBCs? Spherocytes. It is associated with the presence of spherocytes. This is CLL, chronic lymphocytic leukemia. This gets us to our next option, that is ALL. ALL is acute lymphoblastic leukemia. ALL is acute lymphoblastic leukemia. ALL, the minute we talk of acute leukemias, it shows us the presence of blasts. Blasts, are they mature? How many blasts? More than or equal to 20%. Are they mature or immature cells? They are immature large cells. They are immature large cells. What do we mean by large? About 2.5 to 3 times the size of an RBC. About 2.5 to 3 times the size of an RBC. So CLL, it was comparable to the size of an RBC. This is 2.5 to 3 times the size of an RBC with presence of a high nucleocytoplasmic ratio. This is ALL. So before we go further, let us see what it looks like. This is ALL. This is ALL. What we see here is the presence of large cells about 2.5 to 3 times the size of an RBC with a scant rim of cytoplasm. So all these cells, they are lymphoblasts. They are the lymphoblasts seen in ALL. Versus CLL, which showed mature appearing lymphocytes. Similar in size to an RBC. That was CLL. ALL. Next is infectious mononucleosis. Which shows the presence of reactive lymphocytes. All these cells, they are reactive lymphocytes. This microscopy or this image is again important. It shows reactive lymphocytes. So before we go further, let us have a look at infectious mononucleosis. This slide again is important. So infectious mononucleosis, infectious mononucleosis, infectious mononucleosis. Firstly, it is also called as kissing disease. Infectious mononucleosis or kissing disease. Age group, mostly the younger ones, that is 15 to 35 years of age. 15 to 35 years. How is the disease spread? It spreads by saliva exchange. It spreads by saliva exchange, and it is caused by EBV, that is Epstein-Barr virus, caused by EBV. Next point, clinically it is associated with fever, fatigue, sore throat, fever, fatigue, sore throat, and lymph node swelling. Fever, fatigue, sore throat, and lymph node swellings. This is more common. It's a varied presentation, more common. Less often the patient can have rash or muscle soreness and stuff. Next point, rupture of spleen. Rupture of spleen is the main cause of death associated with mononucleosis. Rupture of spleen is the main cause of death associated with infectious mononucleosis. Though this rupture, it is extremely rare. It is rare, but is the main cause of death. Microscopically, it shows the presence of reactive lymphocytes. Microscopically, it shows reactive lymphocytes in peripheral blood. It shows reactive lymphocytes in peripheral blood. Done. This is infectious mononucleosis. So coming back to the question, we have seen all the images with the options. Infectious mononucleosis, it shows reactive lymphocytes, CLL, mature appearing lymphocytes, bacterial septicemia, shift to left with neutrophils, ALL, blasts. Done. This gets us to the next question, that is, now this is an image based question. Before we go further, let us first have a look at the image. What does this show? It shows the presence of, let me project the image on a larger screen so that I am even able to write on it. This is the image associated with the question. I am not interested in what the written MCQ is. First have a look at the question. Image. What it shows is the presence of large cells with abundant cytoplasm, eccentric nucleus. Large cells, abundant cytoplasm, eccentric nucleus. These all are the plasma cells. All these are the plasma cells. So presence of abundant plasma cells, presence of abundant plasma cells makes the diagnosis as multiple myeloma. It makes the diagnosis as multiple myeloma. Multiple myeloma. Next, so this gets us to the question now. Let us have a look at our question and see if everything is fitting into this or not. Elderly, back pain for 5 months, multiple myeloma. No lymphadenopathy, spine shows lytic lesions, sputum culture, strep pneumoniae is performed, bone marrow shows that. So everything is fitting into multiple myeloma. Let us now see the options. Which of the following is true? It is associated with D, that is hypergammaglobulinemia. So answer to question 22 is D, that is hypergammaglobulinemia. Hypergammaglobulinemia. First point. So before we go further, let us just have a look at, I'm interested in 3 points in this: the diagnostic criteria for multiple myeloma, the prognostic factors, and the genetic abnormalities. We'll have a look at these 3 points. You obviously know what they look like microscopically. So starting with IMWG, that is international myeloma, working group criteria. IMWG, international myeloma working group criteria for diagnosis of multiple myeloma. IMWG criteria for diagnosis of multiple myeloma. What this says is, it is a clonal bone marrow plasma cells. More than 10%. Of course, they have to be clonal. It's not a reactive increase. It is a neoplastic increase. Clonal more than 10%, or biopsy proven bone marrow plasmacytosis. First point. The next point is CRAB features. CRAB stands for, CRAB stands for hypercalcemia, calcium is increased, renal insufficiency, anemia, or bone lytic lesions. CRAB features. Should all CRAB be present? No. Any one of these is sufficient to call it as multiple myeloma. The last point is, in absence of CRAB features, more than 60% plasma cells. In bone marrow. These are the IMWG, International Myeloma Working Group classification. Clonal more than 10%, CRAB features, or in absence of CRAB more than 60%. Next point. This gets us to the prognostic factors. Put a double star on this and write down poor prognostic factors. Write down the poor prognostic factors associated with multiple myeloma. They are increased beta 2 microglobulin levels. Extremely important. Next, reduced serum albumin, increased LDH, increased CRP and interleukin 6, and microscopically plasmablastic morphology. These are the poor prognostic factors. What we saw was the classical plasma cells. It was not plasmablastic morphology. I am not even interested in showing you what it looks like. Has to be remembered, the poor prognostic factors. Last point, again put a double star on this and write down ALP is normal in multiple myeloma. Alkaline phosphatase, ALP, it is normal in multiple myeloma. Done. This finishes question 22. This gets us to the next one, that is question 23. Now again, this is an image based question. Forget the theory. Just have a look at the image first. What this shows you, always go by this. See the image unbiased. See the image unbiased. What this shows you is the presence of spindle cells. I'm so sorry, it shows you the presence of sickle cells. That is sickle cell anemia. That is sickle cell anemia. Now, let us look at the question. 26 male, severe chest abdominal pain. So he is having all those vaso-occlusive crises with no lymphadenopathy, no splenomegaly. Which condition is he most likely to have? Sickle cell anemia. So it is associated with the presence of pigmented gallstones. So question number 23. The answer is pigmented gallstones. Why? Because pigmented gallstones, they are associated with hemolytic anemias. They are associated with hemolytic anemias, pigmented gallstones. Gallstones, you very well know, are of two types. Gallstones, most common gallstones are the cholesterol stones. Most common are the cholesterol stones. Most common matlab what percentage? Approximately 90%. 90% are the cholesterol stones, whereas others are the pigment gallstones. Pigment stones. Pigment gallstones, they are associated with hemolytic anemias. Hemolytic anemias, infections of the biliary tract. They are associated with hemolytic anemias and infections of the biliary tract. Whereas cholesterol gallstones, they are associated with 4 F's. That is fat, fertile, female, 40. This you very well know. So sickle cell anemia associated with pigment stones. Done. This takes care of question 23. Done. Thank you.